First of all, thank you so much for being here today on a Saturday, spending some time with us here and learning about Parkinson's. It's truly an honor and a pleasure to be here. I'm Adolfo Ramirez. I'm one of the neurologists here at Fixel. I'm a professor of neurology here at UF. I've been here for about, I think, 9 years or so. So it's great to see some familiar faces. Thank you for coming. And today I was given the task of speaking about the symptoms that people cannot see when it comes to Parkinson's. It's a really big topic. It covers many areas. I personally think that this aspect of the disease has been neglected for so many years that when you go back and look at, I did this experiment. I went back and looked at the textbooks that I had when I was in medical school, not that long ago, I mean a little bit ago, but it's not crazy long ago. And the chapters about cognitive changes in Parkinson's, it was like 3 paragraphs, or no one talked about pain in Parkinson's. No one said anything about gastrointestinal dysfunction in Parkinson's disease, which is a huge problem. And we're so behind on it that we're just starting to learn about how the disease affects these organs and how can we treat them better. Because in some patients, these symptoms could be the most bothersome symptoms, and we have really good treatments. We have heard through the morning that we're really good at treating tremor, slowness, stiffness, but we're having trouble managing some of these other symptoms that are also really important and part of the disease. When you think about Parkinson's, right? When you think about Parkinson's and anyone walks around thinking about Parkinson's, what's the first thing that comes to mind? When you think tremor, right? So yes, hello, my name is Mr. Parkinson's, and what I have, or the way that I think about it, it's based on these common symptoms. Tremor, and we think about tremor all the time, and then we see that on TV and all celebrities that have tremor with Parkinson's, but tremor could be absent in about 30% of patients with Parkinson's. What really defines Parkinson's, the way that we diagnose Parkinson's, it's based on this slowness of movement. Everything slows down in Parkinson's. And it's a good mind frame when you think about all the symptoms in Parkinson's. Everything slows down. Your ability to process information quickly slows down. Your gastrointestinal tract slows down. Your bowels slow down. Your voice slows down. Your voice becomes softer. The movements, even the automatic movements where we don't think about it, all that slows down. And that is the main symptom of Parkinson's disease. Other symptoms are very common too, but we're talking about slowness, stiffness, trouble with gait, maybe shuffling when you walk, difficulty moving your arms. All these symptoms relate to motor problems, mobility problems. And that's how we, to this day, although we have all this technology, and we're actually making big advancements in technology to make the diagnosis, we still rely on identifying these symptoms to make the diagnosis of Parkinson's. So we now know that Parkinson's starts way before you develop the tremors, way before you have the slowness, the stiffness, and the things that makes us think about Parkinson's. But no one is going to go to the doctor if you don't have any of those symptoms, right? You're just going to live your life because you don't have those symptoms that give us the diagnosis of Parkinson's. But Parkinson's is a common disorder. We heard about Parkinson's today and how has the incidence, the prevalence has increased, how Parkinson's affects pretty much anyone. Parkinson's does not discriminate. You can have Parkinson's if you're young, which people thought that Parkinson's was a disease of aging. Not necessarily. Younger people can get it. People with high socioeconomic status, low socioeconomic status, male, females. Males tend to have a little more than the frequency of Parkinson's more than girls, but it's a common disorder. It's probably the largest growing neurological disorder, and it's going to be more frequent than Alzheimer's disease over the next 10, 20 years, unless we do something to try to stop it, right? It was a really beautiful talk by Dr. Dorsey today to inspire all of us. I think that he said it just right. It's our responsibility to make sure that we slow down the disease, and I think that if we're going to be able to find a cure within my lifetime, at least we're going to really try and make that happen. But in parallel, we need to prevent the disease as well. And I think ultimately having 2 approaches, prevention And then treatment or restoration, when it happens, when you have it already, is going to be key. There's a lot of things that cause Parkinson's. Mainly, there's a lot of this complex interaction in the environment. So it only makes sense that if you have a disease that is so complex, because there's a little bit of genetic influence, there's exposure to some of these pesticides, there's these toxins, medications, genetics, age. You can see on this slide how complex metabolic pathways are involved, like the mitochondria doesn't work really well, there's inflammation in the brain, there's alpha-synuclein, all these things happening. It kind of makes sense to think, I'm going to skip on this. It only makes sense to think that other organs are going to be affected, right? It kind of makes sense to think that other parts of the central nervous systems could be affected by the disease. And as I said earlier, these symptoms were neglected or ignored for a very, very long time. As a matter of fact, if you read the original paper by Dr. James Parkinson 200 years ago, he specifically said that these patients that he described have all these mobility problems, but they have perfect cognition, that their cognition and other parts of the central nervous system were intact. In part because we have better tools to assess some of this. We're getting better at asking some of these questions. But now we know that what we see on the surface, when we see in someone that's having mobility problems with Parkinson's, is just the tip of the iceberg. And under the water of that iceberg, we have a variety of symptoms that are also part of the disease, because the disease affects multiple organs. A perfect example I can think of, and I usually use this in clinic all the time, is that people with Parkinson's disease tend to have low blood pressure. And the low blood pressure can happen when you stand up. You can have it when you're sitting, but it's very common when you stand up. And that is because the nerves that go from the heart to the arteries to raise your blood pressure when you stand up are not working really well. Well, you could have that years before you develop a tremor. Actually, in Europe, there's a test that looks for that can help you to diagnose Parkinson's, that damage to those nerves in your heart. So nerves are affected, and other parts of the brain that are really important for other cognitive function may be affected. You can see on this slide that the list of non-motor symptoms is long. Raise your hand if you have Parkinson's and if you have experienced sleep problems. Have you had trouble with constipation? Problems with excessive drooling? Problems with anxiety or depression? Memory is not as good as it used to be, right? Yeah. I'll raise my hand too. Yes, yes. All of us. Yeah. Well, you know, to be fair, I think that we also, in our society in general, we need to allow ourselves to be kind to ourselves and understand that some of these changes happen with aging too, right? It's a privilege to get older too, and it comes with a little bit of slowness, and it's okay. Like commonly people say, well, I'm not as sharp as I was when I was 20. Well, none of us are, right? Because it's just part of getting older. Nonetheless, some of these symptoms in Parkinson's could be quite disruptive. And the first one that I want to talk about that is really important, one that we are really working hard and trying to get better, is the cognitive impairment and the troubles with slowness and processing of information that happens with Parkinson's. It's a cognitive impairment in Parkinson's disease increases with disease duration and with age. And it can range quite a bit from problems with mild cognitive impairment, which means that you're having a little bit, your mind is not as sharp as it used to be, to patients that have trouble helping with activities of daily living. That's what we call dementia, which only means that there was a change in your ability to take care of yourself and the daily activities related to Parkinson's disease. We haven't really know exactly how to estimate or predict that, but there are a couple of really good studies. One of them recently published that suggests that the risk of cognitive impairment, it really increases with age, and it increases with other factors that are associated with Parkinson's. And at 20 years, 15 years, we're talking about that maybe 2/3 of patients may have some degree of cognitive problems. Now, and if you have ever been into my clinic, the first thing I said when someone is diagnosed with Parkinson's is that you want to do everything in your power to be proactive and be as healthy as you can to avoid other things that can affect your memory, right? if you're going to have Parkinson's and with the disease progression, you may have some changes in your memory, you want to make sure that the other things that can affect your memory are taken care of. And there are a few reversible things that we know are important for cognitive enhancement or that can influence cognitive problems. And some of them are really simple. Don't smoke, exercise a lot, and exercise again. Manage diabetes, high blood pressure. That's really key. High blood pressure is probably the strongest risk factor for cognitive impairment in the entire world in general. Manage that. Make sure that your senses are accurate. If you have hearing loss, get hearing aids. Check that out. Make sure your vision is good, right? Treat the sleep apnea. Sleep apnea is a bad player. Let me tell you. If you are working the night shift for years and you never get good sleep, your brain is unable to clear all the abnormal debris that are formed as part of living. So your cells have to go through these metabolic processes, and the only way to clear that of the cells, including our neurons, is with good sleep. Now, it's interesting because some of the studies indicate that 7 hours is the magic number. And if you sleep more than 7, more than 9, it may not be as good. So more sleep may not be good either. So you want to have a certain amount of sleep, and sleep is a hard thing to get when you have Parkinson's. So those are the things that we can do. Cognitive exercises will be really important. And as I mentioned before, this could be a very prevalent symptom during Parkinson's. What do we know about this cognitive impairment in Parkinson's? It's very common when late in the disease, but it could also be present early in the disease in the form of mild cognitive difficulties. And the trajectory of that cognitive impairment fluctuates. Sometimes the cognition gets better on its own, sometimes it slowly worsens over time, and sometimes it's confounded by other things as well, like vitamin deficiencies and some other problems. What is unique about the pattern of the profile of Parkinson's disease memory changes is that it's not really a memory problem. We always say, hey, how's your memory? Just as a form of, in general, we think about brain function as memory. Memory in Parkinson's disease is actually quite good. What it's not good is the secretary of the brain. When you think about your brain and you have a secretary that has to get information for you, right? The secretary becomes really, really inefficient. So the information is there. Your memory is good. What it's hard is to go and get that information. So getting the information, if you're distracted or you're doing too many things at once, the secretary cannot handle it. And then you tell the secretary, hey, what's the name of that guy that I just saw in the street? And the secretary slowly goes and get it, right? 5 minutes later, you remember the name. It's like, oh, that was Johnny. So the executive function, it slows down. And that could be manifested as short-term memory problems simply because your attention is not good. When you are overwhelmed with information, your ability to pay attention, shift attention, becomes very difficult with Parkinson's. Visuospatial skills, depth perception can also be affected. And the most common thing that we see is that processing information becomes slow. And again, processing information, when you give all this information to your secretary is a little slow, so it takes time to get that information through the brain. We very commonly screen for this in clinic. We know that it's important to screen for it because we really want to implement treatments the best we can. And once again, when we talk about treatment and prevention, we need to maximize all these other factors that are reversible. Make sure that you get good sleep, control high blood pressure, manage the sleep apnea if you have it, get hearing aids if you need them, start exercising, manage depression. Depression is also a reversible risk factor for dementia. And then we can consider a variety of medications that have been used in Parkinson's, and actually compared to other conditions in neurology, they could be quite effective. So there's a variety of things that we can do with medications. Probably the most common intervention in our clinic is to get rid of medications that may be affecting your memory. One of them, we commonly use it for tremor. And as the disease changes over time, that medication is like taking a Benadryl every night. It can affect your memory. So we can get off of medications that can affect your memory. That's number one. Then do things that can be really helpful with everyday tasks, like having a routine, getting good sleep, making notes. And addressing obviously hearing loss and some of the things that I mentioned, we typically also get some blood tests to make sure that your thyroid is working well, that it's not a vitamin deficiency that's accounting for this, and then we can do some additional training. There's cognitive stimulation, cognitive training, and cognitive rehab that could be really helpful with some of this. I say it already, but I'll repeat myself. Exercise is tremendous when it comes down to the brain. It's so good that you can actually do it in animal models. So you can exercise an animal model, and then you give them Parkinson's, and then they exercise them, and you don't do the other ones, and the ones that exercise do better. So I know that we're not the same as some other mammals, but it's very clear that exercise enhances. It releases these chemicals in the brain that are protective, and they're released specifically in the parts of the brain that are important for cognitive function. So exercise is key. Now, in parallel to having some problems with cognition, it's not common to have some of these other behavioral and neuropsychiatric symptoms of the disease. These are really important because for the longest time, if you tell someone Parkinson's is a psychiatric problem, they will laugh at you. They will be like, what are you talking about? Parkinson's is a neurological problem. Well, it is, but it leads to a variety of behavioral and psychiatric manifestations that are part of the disease. Probably the most common one is the presence of hallucinations. Now, let me say, this is not something that happens on everybody. And once you are diagnosed with Parkinson's and you go to a support group, you immediately recognize that nobody has the same disease. The trajectory, the progression, the symptoms really varied among patients, although we all share the same diagnosis. So hallucinations are common, and what I mean by hallucinations is that patients may experience seeing, hearing, or feeling things that are not there. This is commonly associated with medications as well. You may have a tendency to have this. Going back to these problems with visual perception that are common in Parkinson's, then as the disease changes, the next step is that you may have false perceptions, like these hallucinations. We can make those worse with medications as well. Dopamine is really important for that function, and too much dopamine at times can create some of those symptoms. It's very common to have complex visual hallucinations, like seeing animals, people, colors. Sometimes they look cartoonish. But then sometimes lights or shapes could be normally seen. The other ones are less common, like hearing things, hearing people talk, or feeling things on the skin. That's actually possible, but it's not very common. At times, especially in people that have moderate to severe cognitive problems, you may also have these symptoms called delusions. And what we mean by a delusion is that people strongly believe that something is happening, although it's not true. Like these false beliefs, and I can give you the most common example is probably feeling that somebody's after you, that someone is, having these paranoid delusions when thinking that someone is trying to do something bad to you, when although that may not be part of it, or believing that you are somewhere doing certain things, although that may not be the case. Depression and anxiety are very common. And I hope that when you come to our clinics, you feel comfortable talking about these issues because we have good treatments for them. Not perfect treatments, but we understand how significant these symptoms are for quality of life, and there are things that we can do about it. Before I move on to depression and anxiety, these problems with hallucinations, with psychosis or hallucinations, they are managed in different ways. And as you can see, depending on where you are in the disease, you can have an increased frequency of hallucinations, but there are a variety of medications that could be quite effective. There are so many things that we can do in clinic. Sometimes, if they're very mild, we don't need to treat them, right? If other things in the disease if the medications that we're using are helpful for other reasons. But at times, especially when they become disruptive or when they're causing a lot of distress, I had a patient that one of the hallucinations that he had is that he would see strangers in the house, and that was very, very disruptive, very, very scary, compared to someone that used to play the piano and actually enjoy having people around him watching him play the piano, or seeing the cat that died a few years ago. It was not that disruptive. So depending on the context of the hallucination also dictates how we're going to manage these things. But we have a few medications that could be really helpful. They could be powerful to reduce these problems. And that's why integrating these symptoms as part of your own disease, your own experience as a whole is really important when we're making decisions. We don't make decisions in a vacuum. You have this, I'm going to give you this. The decisions for treatment need to be after a good discussion with the patient about what's important for your quality of life. What are the things that we need to do to improve that? And balance the mobility part with the non-mobility symptoms. Talking about depression and anxiety, if you think about it, Parkinson's is a chemical disorder in the brain. You have less dopamine. You also have less serotonin and less norepinephrine. We don't talk about that as much as we talked about dopamine, because that has been the main symptom. But those chemicals are really important to support our mood. So it only makes sense that at some point within the disease, you may have low mood and experience some depression. Now, it's also a normal reaction to it to feel upset sometimes for having the disease and dealing with the challenges of the disease, right? Depression in Parkinson's is a little bit different though. And I think that that's why it went unrecognized for so long. Depression in Parkinson's is not the typical melancholic depression where people just want to cry all the time, or they feel sad and they cry all day long. Parkinson's depression manifests more with lack of energy. I don't want to do anything. I sleep a lot. I have no desire to do anything. Those are a little bit different symptoms, and they overlap with the symptoms of Parkinson's, right? I feel slow. So if you add that, you may be fooled and think, oh, these symptoms could be explained by your Parkinson's, but are actually symptoms of depression. About maybe 50 to 60% of patients with Parkinson's may experience some of that. And the important part of it is that we have actually good treatments for it. Just like the way that we try to treat some of the mobility symptoms, we want to treat depression aggressively because it has a lot of impact in other aspects of the brain. We're very fortunate at Fixel to have expert psychiatrists that are experts not only on depression, but experts on Parkinson's disease. About a year ago, Dr. Greg Pontone joined our group, and he's an outstanding resource. If we're having trouble managing depression with your movement disorder doctor, we can have another set of eyes to give us ideas about how to manage depression. One thing that I want to emphasize one thing about it. You always do better if you combine different approaches to treat mood symptoms. So you want to use medications, but you also want to do therapy, counseling, exercise, get good sleep. You have to treat these symptoms in a holistic manner, right? If we do a pill that may help with your mood, that's helpful. But we need to identify the other things that could help with your mood too. If you're going through a really, if there are things that we can, the way I phrase it is usually, are there things that we can get rid of in your life that can help with depression? Get rid of those, right? So we need to treat this as holistically as we can. Anxiety is also a common problem in Parkinson's, and it may occur in up to 70% of patients. It's another symptom that was very deceiving because it doesn't happen all the time. It commonly presents at periods where you have anxiety, and anxiety may present with emotional symptoms or with physical symptoms. If you ever had anxiety, and it's mainly physical, you get palpitations, your heart races, you get sweaty, you feel that you can't breathe, you get really restless, you just don't feel good, or you can have mainly cognitive symptoms of anxiety, feeling that impending doom, you can't concentrate, there's this fear that comes out of nowhere. And it was hard to determine that anxiety because sometimes it happens when the medications are not working. So when you're losing the efficacy of your medications, some people may experience anxiety, and because there are brief times when that happens, people thought, well, it may be related to the medication, it may have not be an anxiety problem, it may be explained by other reasons, but these are actually very common symptoms in Parkinson's, including tightness, restlessness, feeling sweaty, abdominal discomfort is another common one. Especially when the medications don't work. Very commonly people have this hole in their stomach that's kind of hard to describe. And it's under-detected in about 50% of the time and could be most commonly associated with severe motor symptoms. So the treatment for anxiety in Parkinson's is we try to get your motor symptoms the best we can, and then we start using, depending on the type of symptoms that you have, other modalities. We have medications that we use for anxiety. There are some that are helpful, But the best treatment that we have for anxiety is something called cognitive behavioral therapy, which is not going to therapy and sitting on the, you sit on the sofa and talk to the psychiatrist. It's like, so how's life? Well, I went to this conference and, they told me all about Parkinson's and they told me that anxiety could be treated with cognitive behavioral therapy, which is an amazing intervention for anxiety because it focuses on the triggers. Sometimes anxiety could be triggered by something, right? So let's say that you get triggered if you get in a car because you had a car accident, right? Going to the therapist and talking about it is not going to work. What you need to do is work on the emotional mood part of the brain and create new networks of how to manage that, how to cope with those feelings. So it's really, really important. And when you treat anxiety, we try to do a holistic approach as well with medications, with cognitive behavioral training, and then obviously, depending on the factors, try to mitigate some of those. It's very, some of the medications that we have for anxiety could be, we need to use them cautiously because a lot of them can cause also other problems and side effects. So less is more when you have Parkinson's. All these medications, if you took too much of them, can have side effects. So we want to use the lowest amount of medications that are effective in helping you with your symptoms, right? And less is always more. Half of the time I'm trying to get people off medications that sometimes we don't even know they're helping. It's like, what are you taking this pill? Well, for this. Is it help? I don't know. It's like, well, let's try to get you off of it and see if it's really helping or not. We can always put you back on them. Tied to anxiety, depression, and memory, sleep is a really big challenge in Parkinson's. And there are two things that we know that can slow down Parkinson's disease. And I can tell you with certainty, we know this and we have known this for a while. Exercise, moderate to vigorous exercise, and good sleep. Definitely that will help. Now, it's not easy to get good sleep with Parkinson's because Parkinson's disrupts your normal cycles at night. So you have to work on it, right? If for all of your life you just went to bed and watching TV and fall asleep watching TV and it was not a big deal, once you develop Parkinson's, that may not be the best approach. You really need to be proactive to do all the things that will help you to get good sleep. As you can see on this slide, you can have troubles waking up with pain or discomfort. You can have difficulty falling asleep. You can have sleep apnea and wake up with difficulties breathing. You can have to get up in the middle of the night to go to the bathroom. If you're waking up 8 times at night to go to the bathroom, your sleep is going to be interrupted. It's going to be disrupted, right? You can have vivid dreamings and acting out of your dreams, which is it's a pre-motor symptom of Parkinson's. We know that a lot of patients have these acting out of dreams years before they are diagnosed with Parkinson's, up to 20 years. And then REM sleep behavior disorder, if you have it and you're acting out your dreams, you're not awake. So it's more disruptive to the family member. Somebody gets punched. But if he's waking you up and then you get out of bed and you wake up, then it's definitely affecting your sleep. Surprisingly, if you don't, you're going through the sleep cycle like anybody else. What happens is that there's this part of the brain that is not working properly. It's a switch that's supposed to relax your muscles when you're dreaming. Now, Dr. Hess was talking about bring your cards, show your cards, right, when you come to the doctors. And I think that that's really great. So if you need paperwork to be filled, tell me up front. Like, okay, we'll see you in about 3 months. By the way, I forgot about this form. Can you complete it today? But one of the big cards in my mind that you want to discuss up front is sleep, right? Because we need to take time to try to figure out what's the problem with sleep. If the problem is that you're having problems with a lot of urine at night, I'm going to prescribe a medication that's an inhaler called desmopressin that's going to help you to fix that. If the problem is that you are really stiff and slow and shaky at night, I'm going to give you levodopa at bedtime or when you wake up to try to minimize that. If the problem is that you have a sleep arrest and you're snoring a lot, I'm going to refer you to the sleep clinic. If you're having RLS symptoms, you're having muscle pains at night, I'm going to have a different approach to try to help you with your sleep. So sleep cannot be say, my sleep is bad, take this pill, be done with it. There are so many elements, and that's a symptom that you really want to talk up front with your doctors because you're going to spend about 5-10 minutes talking about it and how to get it better. I'm going to skip on this one. I have a few more slides, and I knew that I was going to run out of time, so. There's so much to talk about this. We could do 1 hour on one of each topics alone. An important topic that I really want to also discuss is that Parkinson's disease affects the entire gastrointestinal tract, from your mouth to your rectum. Everything is affected with Parkinson's. And you could have excessive drooling, you can have trouble swallowing, you have trouble with gastroparesis, you can have constipation, you can have excessive bacteria overgrowth in your gut. You can even have problems with the way that we sometimes we think it's constipation, but it's not. What's happening is that the muscles in the rectum do not relax in a coordinated fashion, and it's hard to empty your bowels. But it's not because you're constipated, it's because the muscles are not working right. We know that the entire gastrointestinal tract is affected. You heard earlier today that we suspect that Parkinson's may start in the gut, that it's an early place where we can find that abnormal protein deposits. So we need to treat GI symptoms in a very holistic approach. You can't just take a pill and try to see how you do at home. It requires an intervention. And we're very fortunate here at Fixel that we have a dedicated clinic for complicated cases, where if you're having persistent problems with your GI function, we have an expert GI doctor that's part of our clinic, Dr. Amaris. Manny Amaris is a motility expert. So if you go and see a GI doctor these days, they're going to see you, they're going to say, all right, let's scope you on the top and at the bottom. And if everything looks good, that's it. Everything looks good, see you in a month or see you in a year. The problem is not with an obstruction in Parkinson. The problem is that those neurons are not working right. So they're not contracting right. The abdominal cavity is distended. There's so many other things. So Dr. Amaris, in conjunction with our dietitian, we have a dietitian, a GI expert. We have a couple other people helping this clinic along with a neurologist. We have tremendous occupational therapists that can do pelvic therapy for that problem that I mentioned, that are unable to relax those muscles properly. We can do more advanced testing called manometry as well. And in these cases, when we combine that, we can do speech, occupational therapy, we can do advanced testing doing new techniques like manometry, or we can actually do some blood work as well to try to identify is there a bacterial overgrowth that requires antibiotics. As you can see, there's a lot of things that we can look into and try to support when it comes down to gastrointestinal dysfunction in Parkinson's. So if that's the case, talk to your doctors and we can get you into this clinic. We're trying to expand it. We have it once a month, so it's kind of hard to get in, but we're definitely looking into ways to expand it because we understand how difficult this is. Another common function of this problem in Parkinson's is the genitourinary dysfunction in Parkinson's. And this is one of those topics that very few times we bring up in clinic, right? We always ask about your tremor. I think that we always ask about your sleep. We ask about walking, are you shuffling, how's your tremor, how's your sleep, are you exercising, all these common things. This is another one that you want to show your cards early. If bladder problems or sexual problems are a significant part of your symptoms, you want to bring them up early because we need to ask a few more questions to try to figure out what that is. And we need sometimes expertise from other specialties, including urology. Anorectal dysfunction, sexual dysfunction, urinary dysfunction is very common in Parkinson's. And surprisingly, the medications that are out there to treat bladder problems don't really seem to work that well in Parkinson's. Bladder control is probably one of the most complex things that happen in our brain. There's all these centers in our brain that have to connect with the spinal cord, and then from the spinal cord with all the nerves that go to the bladder. It's super complicated. Like, it really is. You would never think. But there are so many things that could be affected. So we need to ask a few more questions to try to figure out the symptoms, including urgency, frequency, incontinence per se, nocturia, which means having to get up to the bathroom a lot at night, and also sexual dysfunction. There's so many things that could be done to try to help with that important aspect of everyday life, because sexual dysfunction is also common in males and females with Parkinson's disease, but we need to spend a little more time trying to figure out what the problems may be. And in this picture, I have a picture of Rachel Dorsey. She's one of our occupational therapists at Fixel, and she is certified in pelvic therapy for Parkinson's. And when you looked at the benefits of medications versus pelvic therapy for urgency, frequency, or anal rectal dysfunction, physical therapy is actually better. But it needs to be done by someone that is an expert on it. And we're fortunate that we have one person, but it's amazing how combining different approaches could be really important to manage some of these symptoms. I'm running out of time, and I'm just going to stop there because we need to go and eat lunch. I'm sure that everyone is hungry, but I'll be around for questions. Thank you so much for coming and spending some time with us. Thank you.